So it's been a time of intense change, really, with the COVID-19 pandemic. I've never known such rapid change in guidelines, in staff structure, in hospital reorganization. As has been going on in the last few months, it's been really quite mind-blowing in that respect. And like any disease area, it doesn't have to be a cancer area even, but in the lymphoma field, we've very much been affected by this. And really, as the pandemic first started to arise, we had lots of concerns. So one concern was, what do we do if there are suddenly no chemotherapy-trained nurses available to give chemotherapy to our patients? They're all either self-isolating or have the disease, or so we were very concerned about that. Thankfully, now we're past the peak. Obviously, there may be subsequent peaks coming, but the current peak, the staffing sort of crisis hasn't really happened. So we've mainly been focusing our guidance and recommended treatment pathway changes on what we feel is best for patients and safest for patients, not really taking into account delivery capability, because actually that's been okay, which has been wonderful. So the sorts of things that we've been suggesting, we as a UK group and NICE as well have been making these sorts of suggestions. Is basically that the principle is risk benefit. So every treatment has a benefit, otherwise we wouldn't offer it, but every treatment has a risk. And the question is, how much does that risk increase during COVID-19? So if you have newly diagnosed diffuse large B-cell lymphoma or Hodgkin lymphoma, the benefit of the treatment is potential cure. We do manage to cure most people with those conditions. So although the risk has gone up, no doubt, the benefit is still very high. So most centres that I know of have managed to effectively deliver curative treatment, curative chemotherapy, as per standard, with actually relatively little in the way of delays. So that's been great. Obviously, we've been advising strict shielding for those patients to keep them safe. On the other hand, patients with low-grade lymphoma who may be starting to develop symptoms but actually are on watch and wait or are otherwise okay, we've been recommending to hold out on watch and wait for longer, because starting treatment the benefit of starting treatment is more modest than when it's cure, and the risk has gone up. And the other extreme, really, again, relating to low-grade lymphoma, is maintenance treatment. So if a patient with follicular lymphoma is on maintenance, there is a benefit of maintenance, no doubt, but it's a relatively modest benefit. There's a progression-free survival benefit, but no obvious overall survival benefit at all. So the risk has gone up considerably, but the fairly modest benefit has stayed the same. So most centres have been pausing patients with certainly follicular lymphoma and even mantle cell lymphoma, where there is potentially an overall survival benefit. Most centres have been pausing maintenance. I think we have to emphasize, though, we don't know if that's the right thing to do. So, maybe people with follicular lymphoma with their maintenance paused are more likely to relapse early and need second-line immunochemotherapy, and we're right in the middle of the second wave of COVID, so that would be a bad outcome, whereas maybe it would have been better for them to stay on maintenance. So there are lots of imponderables here, and I guess we're just sort of trying to address the issues as best we can with the knowledge we have. So it's strange working in such an evidence-free zone, but because things have happened so quickly, we just haven't had the time to accumulate that evidence. The other big change we've seen, and a lot of centres have seen this, a lot of countries have seen this, is the new rate of new cases has fallen considerably. And we worry about that because I don't think that the rate of new hematological malignancies in real life is actually falling. We assume that patients are not presenting as quickly to their GPs. Possibly the GPs may not be referring as much, but I suspect it's less that. I suspect it's more that first step. Patients aren't going to see their GP as quickly, or, they may have normally gone to A&E with their abdominal pain, but they're holding out and just dosing themselves up with painkillers. These are sort of things we're presuming is happening. So we're rather bracing ourselves for a surge of cases, which may, of course, be later stage and higher risk and needing more intensive treatments. Now, again, it's a bit of an imponderable about what's going to happen, but we're certainly having discussions locally on how we're going to cope with that. And I know those discussions are happening nationally and indeed internationally too. So lots of issues. I mean, we do worry about our patients with lymphoma in COVID-19, more so, I think, than patients who have other cancers, solid tumours. because the lymphoma itself relatively immunosuppresses patients. But then, of course, our treatments, which often use treatments targeted against components of the immune system, such as rituximab, will probably confer an additional risk to patients. And some of the data we've seen coming out, so Ben Goldacre did a huge study of 17 million patients from their GP records, and obviously not all of them had COVID, only a relatively small proportion, but still a lot of patients. And those who had hematological malignancies did seem to have significantly higher risk than a lot of other patients. Age was the overriding factor, but a history of hematological malignancy was a significant risk factor for a poor outcome for those patients. So, shielding is important. Most of our patients are still shielding. One of the big challenges we face is how do we recommend unshielding? Who within that big cohort of hematological malignancy patients should unshield first? How do they do it? How is their risk minimized? I mean, these are, the government is facing these challenges, and hopefully we'll have some advice, but it's again on the basis of very little data. So lots of challenges remain.